every few days or few weeks they develop urticarial rashes, and maybe more than 1 year has passed and few patients come to me. Which drug is safe to be given on everyday basis apart from the acute treatment?
So when you're talking about urticaria,
Yes, sir.
even though it's not from the bacterial infection part, you need to understand that somebody was talking about the follicular urticaria, which I'm not worried about. Papular urticaria, yes, that is insect bite urticaria. I thought you were talking about that. Yeah. So when you talk about urticaria, the classical thing about urticaria is it does not remain in one place. It has to keep changing. If it remains in one place, Shika would be excited. It's a rheumatological disorder where there is vasculitis and it becomes an urticarial vasculitis. What she's talking about is chronic urticaria, an immune disorder, a separate topic by itself. There is an aberrant immune system wherein we go on to immunomodulators. But in the pediatric age group, what we usually tend to do is we increase the dose of antihistamines, especially the non-sedating antihistamines, and we go up to 4 times the dose.
Yeah, so many patients come with loratadine on everyday basis. They are taking since few months but with no relief.
So I just happened to attend a dermatology session wherein the discussion was you select the antihistamine that works on your patient. So you can use loratadine, desloratadine, fexofenadine, levocetirizine, all these drugs, but you need to understand that loratadine, desloratadine, fexo will not cause sedation. Levocetirizine will still cause, because the active molecule in levo is cetirizine. So there you have a little bit, and some people even spoke about using combinations. That is, you have fexo with a levo, fexo with a lora, any combination that works. But what you need to do is these children have to be worked up for an aberrant immune system, and if there is an aberration, we straight away go to immunomodulators.
Okay. Thank you, sir. Thank you.
I have 2 questions coming in from the different centers. Can we take it like a rapid fire? I will skip the questions that are related to bacterial skin infections. So the first question is from Ahmedabad. What should we apply to chickenpox or these lesions, topical application?
You don't apply anything, you don't work. So there is no role for any of these ursocyclovir derivatives on the skin. It has to be taken system orally.
A question from Kolkata says, which topical antibiotics can be applied for prophylaxis of recurrent impetigo?
So when you have recurrent impetigo, you need to find out the cause. So the list is long. Try to first find out whether he's got any immune component, whether he's on any drugs that could predispose, his hygiene status, his occupation, and then you go ahead. That's number 1. Number 2, if you're thinking of a nasal colonizer in the family or in them, you need to decolonize. So what we tend to do is we use the one with the paraffin, the separate preparation for the nose, which is applied twice a day for 5 days, along with the bleach baths are very difficult to use. We usually use bleach in 40 gallons of water, and then we ask them to take a bath twice a day. What we prefer nowadays is we use the chlorhexidine soap that is available. So you get a soap X, and we ask them to take a bath twice a day, and we use the mupirocin twice a day, where the recurrence rate is pretty.
The last question is about cradle cap management in infants, and what if it develops a PD1?
So what
if it develops a bogginess and...
that doesn't happen. PD1 is something to do with the tinea infections. That's tinea papillus. That's an inflammatory reaction. So if you have a Kiria, it's drugs that are given by mouth, the antifungals, that is most important. Seborrheic dermatitis, we already discussed, on the scalp, that's called as a cradle cap, and we usually use only topical applications.
I think, sir, these are the questions that we received from the centers of the work. Thank you so much, sir, for a complete understanding of the subject. Thank you.
So what we did is, I had an Ayurvedic student who was doing a thesis usual way people do thesis is cut, copy, paste. It was there even before the AI came into practice. And with AI it becomes very easy. So I happened to tell her that let's do it. So I took special interest in buying a trichoscope, which is nothing but a handheld microscope to study the scalp and the hair. And why this is important is just prescribing an oil for a hair loss is stupidity. You need to know where the problem is. Is it a hair shaft problem? Is it a problem in the scalp, or is it a systemic problem? So it was so interesting. Her topic was Indralupta, that means patchy hair loss. So it was so interesting that we had a few cases of alopecia areata, wherein with the trichoscope we could tell the patients when they were recovering. And they were using an oil called, this is not allopathy, this is a little bit of Ayurveda. They were using two oils, neem oil and caranjam. Neem oil is again very good for staph. Tea tree oil is very good for staph. So you have a set of patients who get recurrent infections of the scalp. And these are folliculitis, which are really not infected. Some of them are occlusive folliculitis. If you go to the south, it is called as muditude. They put so much of oil, and they have long hair, that they end up having furuncles at the nape of the neck. So this was so interesting. You would look at the scalp and say, oh, this is a discoid lupus. This is a scarring alopecia. This is alopecia areata. Based on yellow dots, white dots. And we started taking photos. Because this handheld microscope will transfer it to a laptop, and from there you can take your photos. And you can magnify it up to a certain extent. And the patient is happy because you are showing them where the problem is. So we had an Everton with hair shaft problem. So you could pick up many things wherein you need not even spend time and money much. And you could have. So it was so exciting. We created a complete this thing, but I am not a qualified dermatologist. I am a general pediatrician, still learning pediatrics under Dr. Ambedkar with terrific interest in skin. So skin and microbiota are very close to my heart. So what I started doing is I assimilated everything and I tried to find out a good teacher. So when we first approached many institutions, they were not very keen on teaching. Till we purchased a book by Roderica, which is considered the Bible or the Atlas of trichoscope. So we are still working on it, and I get somebody who's good, who can teach me things the right way, so that I don't put in my ideas and I have science and evidence to back.
Good morning, sir. Few days back we had a patient in OPD with a diagnosis of so this question is to Dr. Sridhar. So basically we had a patient in OPD with a diagnosis of epidermal nevus syndrome with alopecia areata. So the person was concerned about the swelling lesion on the face. So my question is that how should we approach this case?
I just didn't understand your question. See, first and foremost, if it is alopecia areata, you start to need to look at other autoimmune conditions. So the common autoimmune conditions, thyroid is one, diabetes, pernicious anemia, vitiligo. These are a few things that you should look for when you have alopecia areata. One thing that clinches diagnosis is picking of the nails, like in psoriasis. So you look at the nails for picking. That's one. What is the second thing that the child had?
It came with a diagnosis of epidermal nevus syndrome with alopecia areata 2 months male.
So it was an epidermal nevus. You have a photograph of something that you can send?
Have a discussion later on. We will have a full day dermatology. There is a huge interest. The largest organ of the body keeps intriguing us, and we have many more such sessions. We just can't continue for the sake of time. We'll take a break. Now we have only 10 minutes for the tea break, and then we'll assemble